All right, welcome to this explainer where we're going to tackle ventral hernias. Now look, this isn't just some topic for your finals. This is real-world stuff you're going to see, feel, and get asked about from your very first day on a surgical rotation. Getting this right? Well, it's absolutely fundamental.
So here's our game plan. We'll start with a super clear definition. Then we'll walk through the most common types you'll encounter, umbilical and incisional hernias. And we'll wrap up with the core principles of repair that you'll actually see happening in the operating theater. Let's get right into it.
Okay, first things first. The term ventral hernia gets thrown around all the time. But what are we actually talking about? And, just as importantly, what are we not talking about? Let's clear that up right now. At its simplest, a ventral hernia is just any bulge coming through the front of the abdominal wall. But here's the key distinction you have to remember. We are not talking about growing hernias. So inguinal and femoral hernias? Nope, they're a completely separate beast. A really easy way to think about these is to split them into two main groups. In one corner, you've got your primary hernias. These are the ones that sort of just happen on their own, like a classic umbilical hernia. And in the other corner, you have the secondary hernias, which are almost always iatrogenic, a fancy way of saying they're a direct complication from a previous surgery. Let's kick things off with the one you'll see most often, the umbilical hernia. This one's a fantastic clinical lesson because the exact same anatomical problem needs a totally different plan based on one simple thing: how old the patient is. This is a classic question for your exams for sure, but it's even more common on ward rounds. So, why do we manage these so differently? The answer really gets to the very core of surgical decision-making. It is all about understanding the risk.
Just look at the massive contrast here. In a baby, an umbilical hernia is super common, almost always harmless, and you know what? It usually just goes away on its own. We just reassure the parents. But in an adult, where factors like obesity or pregnancy have stretched out that central fibrous band, the linea alba, the hole that forms is often really rigid with a narrow neck, and that creates a perfect trap for a piece of bowel, making strangulation a very real and serious danger.
And here is exactly what that looks like. It might not seem like a big deal, but please do not be fooled by the size. The danger isn't the bulge itself, it's that narrow, fibrous ring at its base. That's the choke point, and that is exactly why we have such a low threshold for recommending surgery in adults.
Okay, let's move away from the belly button for a second and look at two other primary hernias that pop up in different weak spots: the epigastric and the spigelian.
First up, the epigastric hernia. Picture this as a small but often very painful lump in the upper midline. It pushes right through the linea alba and usually just has a bit of extra peritoneal fat in it. That fat can get nipped by the defect, causing a surprising amount of pain even when it's tiny. And because it's just fat, it can feel a lot like a lipoma, so definitely keep that differential in your mind.
Now this is a spigelian hernia. It's rare, but you've got to know about it. It happens at the side of the rectus abdominis, the six-pack muscle. What makes it so sneaky is that the hernia pushes through the deep muscle layers, but then gets trapped underneath the most superficial layer. So you get this bulge that's basically hidden from view, making it incredibly hard to feel on examination.
So the bottom line for spigelian hernias is this: they are the great pretenders. They're rare, they're dangerous because of that high risk of strangulation, and they often hide from a physical exam. So if you have a patient with persistent, localized pain on the side of their abdomen, you must have a high index of suspicion and get them an ultrasound or a CT scan.
All right, let's pivot to the most common secondary hernia, and honestly, one of the toughest problems in all of general surgery, the incisional hernia, a direct consequence of a previous operation. Seriously, just let that number sink in for a moment. 10 to 50%. That is the chance that a patient will develop a hernia after a major abdominal surgery. This is one of the most common, most frustrating complications we deal with, and the hardest part, it's often preventable.
These two images show the problem perfectly. On the left, that's what the patient sees, one big, diffuse bulge. But on the right, the laparoscopic view from inside tells the real story. It's often not one big hole, but a bunch of Swiss cheese defects. Seriously, when you're in surgery, running your hand along the inside of that scar can feel like driving down a potholed road. This is why a good repair has to address the entire length of that original incision.
So why does this even happen? Well, it's a mix of things. You've got patient factors you can't always control, like obesity or poor nutrition. You've got wound factors, like a post-op infection that weakens everything. But then you have the surgical factors. And that part is in your hands.
It comes down to your choice of suture and, most importantly, your closure technique.
So now that we've covered the types, let's pull it all together and talk about the core principles of how we actually fix these things. This is all about understanding the modern approach to repairing these defects for good.
Now, while open surgery definitely still has its place, the modern way to fix many of these hernias is laparoscopically. By going in with a camera and a few small incisions, we can essentially put a patch on the hole from the inside.
This is exactly what the surgeon is seeing on the screen. We are inside the abdomen, looking up at the anterior wall. That hole you see? That's the umbilical defect, and that yellow stuff is omental fat that's being gently pulled back into the abdomen where it belongs. This inside-out view is just perfect for preparing the surface to lay down a reinforcing mesh.
So, how does it all work? Well, you can really boil it down to a simple 3-step process. First, you gently reduce all the contents from the hernia sac back into the abdomen. Second, you clear away any scar tissue or fat to create a nice smooth surface. And third, you place a specialized mesh inside the abdomen, making sure it overlaps the defect generously, and then you fix it securely in place.
But you know, all this talk about repair really begs the bigger question. How do we stop creating these hernias in the first place? It often comes down to this one simple principle. This quote on the 4-to-1 ratio. It's arguably one of the single most important concepts in preventing incisional hernias. It means taking small, frequent bites of tissue without yanking it too tight, which allows for strong, durable healing.
Okay, let's boil this all down to the absolute high-yield facts for your exams. Number 1, the umbilical hernia paradox. Watch and wait for kids, operate on adults. 2, always suspect a Spigelian hernia with that unexplained lateral pain. 3, incisional hernias are super common, and it's often your responsibility to prevent them. And 4, for adults, using mesh isn't optional. It's the standard of care to stop that hernia from coming back.
So we're going to leave you with this question to carry with you into your surgical rotations. Knowing that prevention is literally in your hands, what are you going to focus on? Every single time you close an abdomen, remember that 4-to-1 ratio. It's not just a technique, it's how you protect your patient from needing another operation down the line.